I'm delighted to be here today to talk to you about the underdelivery of intravenous antibiotics and how this is a hidden contributor to the global antimicrobial crisis. Underdosing of antibiotics results in bacteria being exposed to subtherapeutic concentrations, and this drives resistance. Failure to ensure the full dose of intravenous antibiotic administration leads to treatment failure as a direct worst-case scenario, with longer-term dangerous consequences through antimicrobial resistance and the development of drug-resistant infections. Reducing the antibiotics used in hospitals and incorrect disposal of antibiotics are key strategic approaches to drive down drug-resistant infections. Firstly, it is important to understand how underdosing occurs. Quite simply, it is a result of residual fluid containing the active drug remaining in the administration sets, which is removed and disposed of at the end of the infusion. Depending on the initial volume of the antibiotic to be delivered, and the dead space within the giving set being approximately 16 mils, between 20% to 40% is subsequently lost. As well, in the obvious concerns of treatment failure and long-term antimicrobial resistance, with over 1 in 3 NHS patients being on antimicrobials at any given time, every wasted dose has an associated cost which can quickly accumulate into substantial financial losses. Within this context, when I speak of line flushing, I'm talking about the complete flushing of the administration set tubing, including the drip chamber. This is the only way that the full dose will be delivered. It is routine practice for extension sets to be flushed when boluses of medication are given and on disconnection of an intravenous infusion. However, this does not produce the same results and leads to underdosing. Underdosing can be seen as a double-edged sword, as incorrect disposal of remnants of antibiotics in unflushed lines has contributed to environmental contamination, which is regarded as a strong driver of antimicrobial resistance. When I first started my nursing career, many things were very different, including the way we delivered antibiotics and intravenous fluids and medication. We used a burette system, and our normal practice was to instill additional fluid into the burette chamber at the end of any infusion to rinse the line. It was easy to do with this system. With the introduction of infusion pumps to support safer, more controlled delivery of medication, this practice was lost and underdosing occurred. Underdosing has been created unintentionally, overlooked by many, with an immeasurable impact on our patients, antimicrobial stewardship, and our environment. Whilst we are unable to turn back time and amend what has been missed in the past, we now have the opportunity to make things right again. Certain specialities, namely oncology, hematology, and pediatrics, have retained line flushing with the use of piggyback systems. Within these fields, delivery of full doses of chemotherapy, etc., are crucial. However, it is arguably essential for all our patients. As a healthcare clinician, you have an inherent desire to always strive to do the right things for your patients. As a healthcare clinician, ensuring that patients receive the full amount of the drug therapy that they are being prescribed is a fundamental part of healthcare, and it is widely understood to be a key priority for all staff charged with administering intravenous drugs to patients. In the years that we were oblivious to the lost practice of flushing our intravenous antibiotics, meant we were also oblivious to any ethical and legal deficits in our practice. Now we are cited on this, it is perfectly clear that we must adopt this practice. Ethically, it is wrong to deny patients the full dose of their treatments, and as clinicians, we are accountable for our actions. and any omissions in administering medications resulting in patient harm has potential legal repercussions. The impact of underdosing is multifaceted, affecting antimicrobial resistance, patients, and the environment. Antimicrobial resistance is now posing one of the biggest threats to global health, food security, and development. Misuse of antibiotics accelerates the naturally occurring antibiotic-resistant processes. Under-delivery of antibiotics means that desired effective therapeutic drug levels will not be achieved, which not only delays recovery from infections, but is also a contributor to the development of resistant strains. Whilst there is limited research that exists directly linking underdosing with both worsened outcomes or drug-resistant infections, the logic of the need to do this is enough. There is, however, a clear need for further studies to compare patient outcomes with the level of underdosing by monitoring the extent of underdosing, by collecting used administration sets, and establishing the volume of drug remaining at the point of being discarded. As previously mentioned, antimicrobial resistance is one of the World Health Organization's top 10 public health threats facing humanity. The figures here are particularly alarming, with 700,000 estimated deaths globally due to antimicrobial resistant infections, which, if left unchecked, could rise to 10 million by 2050. With no new classes of antibiotics discovered since the 1980s, the AMR challenge appears a daunting one. We have a responsibility to address the overuse and misuse of antibiotics in human medicine. Reducing the suboptimal dosing that takes place and the environmental spread of AMR through pharmapollution is essential in combating the problem and arresting the advancements of antimicrobial resistance and the development of drug-resistant infections. Cancer patients are particularly vulnerable to infections, which are the second leading cause of death among cancer patients and lead to 1 in 5 being hospitalized during treatment. With advances being made in cancer treatments helping more people to survive cancer, it is a travesty if they ultimately die of an infection that was previously treatable. Interventions are required to improve our use of antibiotics through eliminating underdosing by introduction of antibiotic line flushing policies nationally, supported by dedicated training in correlation with the monitoring and management of environmental antibiotic contamination. With overuse and misuse of antibiotics, which underdosing contributes to, antimicrobial resistance has become more prevalent over time. The impact of underdelivery of antibiotics on clinical care leads to significant deficits in healthcare efficiencies, with consequences for clinical outcomes, financial and operational management, and the environment we live in. Underdosing of intravenous antibiotics leads to therapeutic drug levels not being reached, which delays recovery, as well as the ability to switch from intravenous to oral antibiotic treatments. This will inevitably lead to increased lengths in hospital stays and the need for second or third line antibiotics to be prescribed. Again, this will result in a further financial burden on medication costs, as well as an increase in the use of consumables to deliver the additional treatments. In the UK, drug-resistant infections cost the NHS £1 billion annually. In June 2023, all UK hospitals received a Freedom of Information request from the House of Lords to understand how NHS organisations use and dispose of antimicrobials when given as an intravenous intermittent infusion. The report was launched in November of last year. I would recommend reading this report. It provides a strong foundation on which to enact change to stop underdosing through policy and practice change. A summary of the key findings found that 70% of organisations did not have a line flushing policy, And of the 30% that did, only 12% demonstrated that they were compliant with their policy. 24% of organisations claimed that the practice of detaching the drip chamber from the line was commonplace, which, as we know, results in antibiotics being disposed of in waste streams. The findings from this report recommended the need for a concerted UK-wide action on antibiotic line flushing policies with cross-sectoral engagement supported by UK government through the Department of Health and Social Care. The findings of the report clearly showed that practice deviates from guidelines produced by several UK organisations, the National Vascular Access Society, the Royal Marsden Manual of Clinical Nursing Procedures, and the Medusa Injectable Medicines Guide instructions on how to administer intermittent infusions. All of these stipulate that all of the prescribed medication should be administered. So how do we overcome this problem? There are two recommended methods for this. One is to attach an additional bag of compatible fluid to rinse the line through at the end of the infusion. A second method is to use an administration set with an injection port above the drip chamber in which to instill the additional compatible fluid to flush the dose. Method 2 has benefits over method 1, as it does not require a break in the intravenous circuit, reducing the risk of bloodborne infections, and additionally, the amount of fluid used to flush the line is limited to just the amount required, beneficial for fluid-restricted patients. You'll be able to see a demonstration for this method at the B. Braun stand, so please do stop by to see it in practice. One driving factor for creating these guidelines was the identification by NHS England of a risk of harm from underdosing when intermittent intravenous infusions are not followed with a flush to deliver the full dose of the medication. To not ensure that the complete administration of prescribed drug can lead to treatment failures. Additionally, disposal of unflushed lines causes active antibiotics to pass into hospital effluent, directly contaminating the environment, or discarded in plastic waste bags, where it can permeate into the hospital environment via vapours. Here, we need to consider the safety of healthcare workers and their right not to be unnecessarily exposed to medications in the workplace. It is quite incredulous to read this quote from Florence Nightingale, who said, "For us who nurse, our nursing is a thing which, unless in it we are making progress every year, every month, every week, take my word for it, we are going back." Whilst the advancement of infusion pumps with their safety features and time-saving qualities meant line flushing became a lost practice and under-delivery of full doses of antibiotics occurred, we need to continue to progress our practice to make sure we don't go back, but maintain advances in our healthcare delivery and sustained innovation, both of which underpin our ability to provide safe, effective care to produce the best patient outcomes, combat antimicrobial resistance processes, reduce drug-resistant infections, whilst driving down unnecessary costs. We all need to play our part here, from pharmaceutical companies having responsibilities to include the practice in drug literature and IV administration guidelines, and research bodies can support with studies into clinical impact of reducing drug loss in terms of patient outcomes using specific measures such as therapeutic dose monitoring, inflammatory and biochemical markers, as well as looking at length of treatment, length of hospital stay, and mortality rates. We all know that the NHS is experiencing enormous operational pressures. Any measures that improve patient outcomes and reduce additional burdens from ineffective practices are fundamental. Flush the line every time, an easy solution to a serious problem. Thank you.